Good morning, everyone. Today, Dinesh will be presenting and will be moderated by Professor V.K. Kapoor, Professor Venu Madhav, and Professor Nagaraj Palankar. So it's all yours, Professor Kapoor, Professor Venu Madhav, and Professor Nagaraj. You can take over now.
Good morning, sir.
Yeah. Dr. Dinesh, you can start your presentation.
Yes, sir. Good morning, everyone. Today I'm going to present a case given by me. 39-year male patient, laborer by occupation, resident of West Bengal, came with the chief complaints of pain in the upper abdomen since 4 years. History of presenting illness: patient was apparently all right 4 years back, with he started having complaints of insidious onset, dull aching, mild to moderate epigastric pain, radiating to back, aggravated after food intake, and relieved with oral analgesic with history of increase in intensity since 1 year. Pain is gradually increasing in intensity and frequency. A repeated episode of severe pain, initially once in 2 months to weekly over last 3 months. Pain which is interfering with the daily activities, due to which patient has stopped working since 1 year. History of loss of appetite and loss of weight. There is significant weight loss is there. 15 kg in 6 months present. History of passing pale sticky stool since 3 months. He was evaluated and started on oral medication. I want to know whether pancreatic enzyme replacement therapy is given or not. History of passing black tarry stool or there for 2 days 1 year back. Further any intervention done or not. History of weakness of muscle and bone pain present. No history of hematemesis, fever, pruritus, jaundice. No history of abdominal distension, vomiting, fullness, heartburn, regurgitation. No history of dryness of eye, easy bruisability, or any other previous blood transfusion. He was admitted elsewhere for pain management with injectable drug on multiple occasions in the last 6 months. Whether IV opiate analgesic was given or not, I want to know. Patient was evaluated with the ultrasound and started on oral medication. I want to know whether patient had when was the last acute exacerbation event, when there was any ICU admission or not. I want to know. However, in view of persistent complaints, patient referred to tertiary care center. Past history: patient is a known case of diabetic mellitus since 7 years, on insulin requirement since 4 years. No recent change in insulin requirement. No history of any surgery. Family history not significant. Personal history: patient sleep is disturbed and appetite also reduced. Bowel bladder habits are normal and regular. Consumes a mixed diet. Is an alcoholic. Consumes around 90 to 180 ml whiskey per day. Abstinent since 3 months. Tobacco chewing present. To summarize, sir.
Yep, continue.
Can you please go back to your first slide, the presenting complaints? Even before this? Yes, the next one. Here you said pain in the upper abdomen. Upper abdomen
Yes,
could be right upper abdomen, could be central upper abdomen, could be left upper abdomen. If you had here only said pain in the central upper abdomen, if the patient has said so, that would restrict the discussion to certain organs. So the first presenting complaint should be as specific as possible. Also, in the history, is there no other chief complaint?
This was the chief complaint given to me, sir. That's why I didn't add any other thing.
Yeah, so different terminologies are used. If you say chief complaint, then obviously you select one. But most commonly it is the presenting complaints, which could be one, which could be multiple. Retrospectively, do you think there is any other point in the history which is important? Because I'm saying this because many examiners would stop you at this stage before you go into the details of the history and say that as soon as the patient comes to you in the OPD, what starts rolling in your mind? So with this alone, it becomes very difficult because it is very diffuse, very vague. On the other hand, if you had said significant loss of appetite and weight and stool disturbance, which is pale sticky stool, that would restrict the discussion to pancreas. Go on to the next. Now, is this enough to say history of passing pale sticky stools? What are you trying to hint at?
Sticky stools mostly in case of I want to think of a steatorrhea history, sir. But in steatorrhea, there will be a large, voluminous, greasy, oily, foul-smelling, frothy, sticky stool. Sometimes floating also.
You didn't mention any of those characteristics, whether they are present or absent. So both in history and examination, definitely all positive points, but important negative points need to be highlighted. If that history is not there, you should have said that his stools are pale and sticky, but he does not give history of passing large volume, frothy, foul smelling. When you say these negative points, it automatically tells me that you know what is steatorrhea. Otherwise, I have to ask the question. The attempt of every student in the exam should be that the minimum number of questions are asked from you, and your description alone is good enough. Now, you want to know whether it was PERT. Can you not by history make out whether it was PERT or not? By asking some leading questions?
Sir, I want to ask whether the patient has taken along with the meals or not. Other in
Very,
between meals.
very clear. Whenever an enzyme is prescribed, the patient is specifically told that take it with the meal. And the dose with breakfast is less, the dose with meal is more. So it will be either different tablets or it will be one tablet at breakfast and two tablets at meal. So many times when the patient doesn't know what he or she is getting, by asking some leading questions, you can know. ATT, it will always be a packet of 3 or 4 drugs which are all taken together. It is the duration. Steroids, most good doctors will prescribe that you take some PPI or some H2 blocker with steroids. Don't take it fasting. So by asking leading questions, you can know rather than saying that I would like to know whether it is PERT or not. Next, at some stage, you said that I wanted to know whether he has had an ICU admission. Why do you want to know that?
In case of any severe acute pancreatitis, suppose in previous history. So I want to know.
These patients can have only severe acute pancreatitis, not just acute pancreatitis. What you should have said, I want to know whether he has had episodes of severe pain in addition to or superimposed on the baseline pain, which was associated with nausea, vomiting, retching, which required either hospitalization or at least injectable treatment, which is more than what he is otherwise requiring. That would tell me that you are asking for history of an episode of acute pancreatitis. Okay?
Yes, sir.
Go to the summary.
To summarize,
You mention about family history?
That's not significant.
You did mention. Okay, fine. Please carry on.
13-year male patient, laborer by occupation, known case of diabetic mellitus for 7 years, on insulin requirement for last 4 years, is an alcoholic and tobacco chewer, presented with the complaints of epigastric pain since 4 years, dull aching, right? Mild to moderate intensity, radiating to back and aggravated after food intake, which relieved with oral analgesic initially, with recent worsening of character of the pain for the last 1 year, even after taking the IV analgesic, which interferes daily activity and quality of life. With the associated history of significant loss of weight and appetite, with the history of steatorrhea and muscle weakness, bone pain. No history of jaundice or abdominal fullness or ill satiety. My differential diagnosis be chronic pancreatitis, exocrine and endocrine insufficiency with possible malignant changes recently. And I also keep in mind that it's a less possible chance, but I want to also keep this differential diagnosis as chronic gastric ulcer with malignant change. Least possible chance.
So Dinesh, what makes you think about chronic gastric ulcer in history here?
Sorry, pain in the epigastric region, and the patient is an alcoholic. Age is also around 40 years of age. Then immediately after taking food intake, pain is aggravated, sir.
And how is it relieved?
Sorry, sir.
What are the relieving factors here?
Relieving, initially it's relieved with the oral analgesic, sir.
So is that the pattern of pain one can expect in gastric ulcers?
It's a periodicity will be there, sir. Initially there is after sometimes the pain relieves on its own.
Yeah.
After sometimes again the patient develop a pain.
Yes. So this pattern doesn't suggest pain of gastric ulcer, isn't it?
Yes, sir. I just want to keep it as the least possible cause, sir.
There is something else in the history, which, of course, raises the possibility that there might have been ulcer at some point. Did you notice anything suggesting that patient might have had an ulcer sometime?
Yes, sir. Patient had a history of melena, sir. Mainly, most likely due to the intake of high analgesic, continuously intake of analgesic, NSAID may be the reason
Yes.
it leads to ulcer.
Yes. So apart from an ulcer, what else, comes to your mind if somebody gives history of melena?
Sir,
Or
in
this
case of
patient
a
specifically this patient.
yes, sir. Most likely this is a case of chronic pancreatitis. If patient present with melena, I would like to think there is a chance of complication of chronic pancreatitis in the form of there may be a thrombosis in the splenic vein leads to sinustral portal hypertension, may leads to variceal bleed, or then there may be a chance of hemosuccus pancreatitis. It can present like a GI bleed, sir.
Yeah.
Why
So
do you say possible malignant change?
Sir, from the history, the character of the pain is worsened in the last 1 year, sir, even after taking the IV analgesic, and there is a significant loss of weight and appetite is there, sir. So this
Taking
two,
IV analgesic is not reflecting the character of the pain, it reflects severity of the pain.
yes.
Character means that earlier he used to have intermittent episodes of pain and now he is having continuous pain. Need for IV analgesic indicates the severity of the pain, not the character of the pain. Any other point? For possible malignant change? Does he really have loss of appetite or is he not eating because eating precipitates the pain? See, in chronic
Both ways
pancreatitis,
may be there, sir.
you have to be clear. You have to ask that question because patients with gastric ulcer, patients with chronic pancreatitis, patients with mesenteric ischemia, they may have normal appetite, but they know that as soon as they eat, they get pain. So they stop eating. They eat less. So there may be no loss of appetite, but still they may be losing weight. Also, they would lose, even if they are taking adequate diet, they may be losing weight because of steatoria. So this is one condition where you have to be very careful about weight loss. It doesn't necessarily, yes, I agree, it is one of the indicators, but it does not necessarily indicate weight loss. Same holds true about inflammatory bowel disease. Patients with inflammatory bowel disease may have normal appetite, but they lose weight. Patients with diabetes may have normal or even increased appetite, they would lose weight. Thyrotoxicosis, increased appetite, but they would lose weight. So you have to keep these possibilities in mind. I'm not saying that here you think of diabetes, he is definitely a diabetic or thyrotoxicosis, but chronic pancreatitis, you have to be very, very careful.
Recent worsening of diabetes is also one of the indicators for the.
Yes, sir, but in this condition, they in the history they are given specifically there is no recent change in insulin requirement.
Yeah,
Yeah,
so
but in summary, you didn't mention anything about the melena. Do you think it's insignificant, or how do you know that melena was significant or insignificant? You want
Sorry,
to
sir?
melena? You didn't mention anything about the melena in the history.
Yes, sir. Actually, melena, the recent worsening of the pain is in the last 1 year only, sir. But the melena occurs 1 year back, that also for only 2 days. So I am thinking most likely due to analgesic in
How do you assess the severity of that?
erosion.
How did you assess the severity of melena that time? Did you ask? Did you wanted to
Whether
ask?
the patient associated symptoms like syncope, syncope is there or not?
Yeah, you didn't mention that.
Any intervention done?
Yeah,
any blood
nothing
transfusions
is
given?
mentioned in the history, but you should ask because
Yes, sir.
that's a significant event in a case of chronic pancreatitis with melena. It has to be evaluated. Must have been done. Any endoscopy was done. Just like that, they don't leave it. So you have to take it a little bit more seriously. So how do you characterize pain in chronic pancreatitis? How do you evaluate pain? How do you grade it? in this patient, what do you think is the severity of
This patient is a grade C, sir. Patient is having a severe pain. It's not persistent pain. Even after taking the analgesics, the analgesia requirement also high, and it will also interfere the quality of life also, sir.
It is interfering. So do you know about any scoring systems? for
Sir,
pain?
ABC scoring system is there.
Okay. So it's
And then ISBK score.
what is
ISBK scoring system is there.
so what is DBK score?
Sir, ISBK is there is a pain character of the pain, whether it is relieved, whether it is a mild or severe type of pain, whether it is analgesic requirement depends upon the analgesic requirement, whether initially whether it relieves with analgesia or persistent. Even some patients in type B3, type 3 severe pain will be there, and sometimes the pain is relieved with analgesic, but quality of life will be interfered, sir. In type 4 type of pain, there will be severe pain, and requirement of analgesic also high, and even though there won't be any substitute pain, there won't be a pain relief,
So
and
four
there is a
four components are
significant
important.
quality of life.
Four components are important. One is frequency of pain. Daily means it's more severe. Visual analog scale, higher intensity is more. Analgesic medication, usage of opioids, and of course, inability to work. You mentioned all this, but not only the visual analog scale, inability to work and frequency of pain is more important. So what is this diabetes? How this diabetes is different from in chronic pain, different from other diabetes?
So in case of chronic pancreatitis, the diabetic is the type 3C. We used to tell pancreatogenic diabetic is the type 3C. In this case, usually there is a destruction of the, pancreas is burned out, so there may be loss of counter-regulatory hormones also present. So like a glucagon and polypeptide also is there. So there, the brain cannot signal the hypoglycemia.
Yeah, good. So there's lots of both counter-regulatory also. So
there is
so have you after this examination? So what is your possible differential diagnosis? You said chronic pancreatitis malignant change. Do you think you stick to the diagnosis, or do you think and chronic gastric ulcer with malignant change? Do you think both of these, or you want to revise based on this summary?
No, so I want to stick with the chronic pancreatitis with the exocrine and endocrine insufficiency with possible malignant changes.
Going back to the question which was asked of you, the severity of melena, before you go on to symptoms of acute anemia, fall in hemoglobin and others, it is the number of stools, it is how many days the melena lasts. Suppose the patient passed just one stool in the day and it was melenic, and after that the patient next day passes normal stool, that means it is small amount of blood, because blood in the bowel always causes hyperperistalsis. So if there is significant amount of blood loss in the GI tract, patient will have frequent stools, more frequent than normal. The color of the stool will remain black for more number of times or more number of days. So that also would suggest that how severe the melena is before you go on to symptoms of anemia and fall in hemoglobin. Okay, yes, please proceed.
Shall I proceed with the examination, sir?
Yeah.
Dental physical examination. Patient is conscious, cooperative, oriented to time, place, person. Patient moderately built and nourished. ECOG 1. Weight is 50 kg. Height is 126 cm. BMI is 19. No pallor, icterus, generalized lymphadenopathy, clubbing or pedal edema. Afebrile. Pulse rate 90 per minute. Vitals stable within the normal limit. Oral cavity, tobacco staining present. On parectomal examination,
Go
on
back,
inspection.
go back, please. Go back, please, to general physical examination. He's how old is he? 36.
39.
39. So 39-year-old laborer, pulse rate of 90 is normal.
Yes, sir.
90 is a normal pulse rate for a young man.
When can pulse rate increase in chronic pain in these patients?
If he is a laborer, what is his pulse rate likely to be? More than normal or less than normal?
Less than normal, sir.
All the more that 90 is not normal for him. What could be a possible cause?
There may be due to pain.
Yes, pain can cause tachycardia.
Then underlying some inflammation or sepsis, underlying mild sepsis can also lead to some rise in pulse rate.
Yeah, so you can't pass it on as normal. You have to say that his pulse rate is more than normal. And then if the examiner asks, you have to give possible explanation. It is possible that he has been having blood loss, occult blood loss, which he hasn't noticed. He is pale, although you could not detect any pallor. But he is a laborer. Most probably his sclera will be muddy. It will be very difficult to detect mild pallor in a muddy sclera unless he has severe anemia. Okay, please carry on.
On inspection, abdomen is flat, umbilicus is centered and inverted. All quadrants moving equally with respiration. No cause engorged vein, visible peritonitis or visible pulsation. Hernial orifice, no visible cough impulse. On palpation, soft and non-tender. No organomegaly or palpable mass. No splenomegaly. No palpable cough impulse. Percussion, liver dullness, upper border palpable at fifth intercostal space in right mid-clavicular line. Liver span is around 13, about 13 centimeter in right mid-clavicular line. Lungs are tympanic. And auscultation, normal bowel sound heard. Digital rectal examination, normal sphincter tone, no melena. So I assume there is no greasy oily stool. Other system examinations are normal.
I'm happy that when you describe the per rectal examination, you specifically mentioned the important negative findings that there is no melena and there is no greasy oily stool. So it is not enough to say that PR is normal. We expect that you should say what important negative findings which you were looking for are not there. Okay, please carry on.
13-year male patient, labored by occupation, known case of diabetic for 7 years, on insulin requirement for 4 years, is an alcoholic and tobacco chewer, presented with epigastric pain since 4 years, dull aching type, mild to moderate intensity, radiating to back, and aggravated after food intake, which relieved with oral analgesic initially with recent worsening of the character of pain for the last 1 year, even after taking the IV analgesic, which interfered the daily activities and quality of life, with history of significant loss of weight and appetite, with history of steatorrhea, muscle weakness, bone pain. No history of jaundice and abdominal fullness or early satiety. And general physical examination, pulse rate is 90 and its BMI is around 19. BMI is 19 kg per meter square, and per abdomen examination unremarkable. My diagnosis, I want to give you one diagnosis: chronic pancreatitis with exocrine and endocrine insufficiency with possible malignant changes.
One more possible cause of melena which we did not discuss is that, as you are saying, if there is chronic pancreatitis with malignant change, these patients would develop usually a malignant change or a mass in the head of the pancreas, which if it is infiltrated the duodenum and the mucosa, that can cause melena. Okay, so see a head pancreas infiltrating duodenum, a primary duodenal carcinoma, a carcinoma of the gallbladder which is infiltrating duodenum, and a papillary or a peripapillary periampullary carcinoma. These all can cause melena or occult blood loss. Okay, please carry on. What would you do?
I want to review the previous ultrasound. So the ultrasound was done one time. I want to review that, and along with that, I want to do the complete hemogram, liver function test, renal function test, PT-INR, CRP of this patient. Then I am suspecting a malignant potential, so I want to do CA 19-9 also in the same setting.
Any other test you have missed? Chronic pancreatitis, doubtful history of steatorrhea. Do you want to
fecal elastase, fecal elastase test.
Stool for fat and then fecal elastase. Okay, let's see the investigation. What I'm trying to say that don't mention these investigations as a routine in every case. Think what specific investigations would be required in a case like this and mention them.
After summary also you mentioned chronic gastric ulcer with malignant change, but you are
Sir, I will keep it at only
He has
chronic
retracted
pancreatitis.
that. He said that he would like
But
to keep.
endoscopy you didn't mention, that's what I'm doing.
Yeah.
In your list of investigations, you want to do or you don't want to?
First, I want to see the ultrasound abdomen, sir, first, because already then ultrasound abdomen. Then after that I.
Yeah, so
After
even
that.
if the previous ultrasound report is not there, your answer should be, I would first get an ultrasound done. In all likelihood, it will tell me whether I am dealing with chronic pancreatitis or not. If it shows chronic pancreatitis, then I am not thinking of gastric ulcer. If it doesn't show any change of chronic pancreatitis, then definitely you can go back and say that the possibility of chronic gastric ulcer is there and that history of steatorrhea is doubtful. See, again and again, I say that at MCH level, it should not become a question answer session that we ask you a question and you give an answer. It should become an intellectual discussion because tomorrow you will be a consultant. Today, if you go to a medical college, you are a consultant. So it should be more an intellectual discussion. Yes, let's see the ultrasound.
Even if ultrasound is showing chronic pancreatitis, do you want to do endoscopy or you don't want to?
Yes, sir, I want to do endoscopy, sir.
Why?
After seeing there may be complications of chronic pancreatitis, I want to see whether splenic vein thrombosis is there or not, and the portal hypertension may be there. So
You will
sinestal
not see
No, in this
splenic vein
patient.
thrombosis on upper GI endoscopy. What would you see? What would you see? Would you see splenic vein thrombosis on upper GI endoscopy?
No, sir. I just telling it in case of chronic pancreatitis, if it is complication of chronic pancreatitis, even though if it I'm considering a chronic
What would you
pancreatitis, I would
see
like to
on
see.
what would you see on upper GI endoscopy if chronic pancreatitis is complicated by splenic vein thrombosis? You haven't still said that. To say that, your answer should be, I will still do an upper GI endoscopy because it may show presence of gastric varices, which would indirectly indicate that the chronic pancreatitis has got complicated by splenic vein thrombosis. Show your knowledge. Yes, let's see the ultrasound. As far as possible, don't give single word, single phrase answers. Say complete sentence, show your knowledge related to the question which has been asked. But first answer the question. Yeah, are you able to project the ultrasound report?
Okay. Do you have the hematological investigation?
Yeah, it's coming.
What
Yeah,
is
there is a comment in the chat. Anonymous, please don't join as anonymous attendee. Be bold enough to put your name on the chat. Dr. Pradeep has said this so many times. We should know who is the student. The question is pseudoaneurysm in CCP can also cause melena. Yes, I think you did mention both venous and arterial complications. Yeah. He did mention hemosuccus pancreaticus also. Yeah, let's see the ultrasound report, please.
You said stool elastase. How is it going? How are you going to interpret that, and what are you going to get it from stool elastase? You are telling, but mention no stool elastase you wanted.
Sorry, sir.
What is your interpretation of fecal elastase? You said that.
Sir, if it is fecal elastase, it is less than 100 microgram, then it will be a severe pancreatic exocrine insufficiency, sir.
Why only fecal elastase? Why you want to do specifically go for? Why can't you test other enzymes?
This is more specific for to detect a exocrine insufficiency.
Are you not having the control of the slides?
No, sir.
1 minute. Yeah.
Dinesh, you stop sharing it.
see the
Yes,
slide?
sir. Yes, sir.
Yeah.
No? Hello?
Yeah, go ahead.
Yeah, show us the reports one by one. Start with the ultrasound first, maybe. Yes. What does it show?
I'm not able to see, sir.
You're not able to see?
No, sir.
So it mentions pancreas,
Yes,
thyroid.
sir.
We
Yes,
can
sir.
see it. We can see
Now
it.
I can.
Why?
Yes, sir. So in this ultrasound suggestive of chronic calcific pancreatitis, sir. With from the ultrasound, there is no local complications. And the liver, no signs of any CLD features.
It's not enough if you just say that, ultrasound is suggesting chronic pancreatitis. There is more information there,
Yes, sir.
What more is important from your point of view, from surgical point of view, which is there in the ultrasound?
The dilated
Hugely dilated, 15 mm.
pancreatic duct.
You should say that, hugely dilated duct, isn't it?
Yes, sir.
And you rightly said that there is no evidence of any complications. I'm surprised why they have specifically mentioned no mass lesion in the iliac fossa. Was there any suspicion, any reason, any indication of their mentioning that? Normally, you wouldn't mention that.
No suspicion was there, sir.
Okay, so this ultrasound was done when?
This was done at admission with us. This was done at admission, sir. Outside reports were not available with him, so we had to do a new ultrasound.
So is this a recent ultrasound?
Yeah, recent one.
Okay. Now what would you do with this ultrasound?
So I want to
Dr.
see the
Nagaraj,
blood
Dr.
investigation.
Venu Madhav,
Yeah.
any question you want to ask
Yeah,
him on
yeah,
ultrasound?
Dhanesh, you mentioned about, complications. I mean, the complication of chronic pancreatitis. What all did you look for on ultrasound?
So I would look for any pseudocysts is there or not.
Yes.
Then any collections. Then splenic vein thrombosis. They are not mentioned about the portal vein and the splenic vein. So and the splenomegaly is there or not.
Yeah. What else?
Any arterial, any specific arterial, if they want to see any arterial pseudoaneurysm is very difficult in ultrasound, but
Yes.
still if it is a prominent, they can able to tell.
Okay. What else?
Any biliary complications like HBID is there or not.
Yeah, that's right.
So
Anything
again,
else?
whenever a report is shown to you, after describing what is mentioned in the report, you should point out the deficiencies in the report also, what you wanted and what is not there. That again tells me that you know what is to be looked for in a particular investigation. So whatever is, the portal vein was mentioned. You said portal vein is not mentioned. Portal vein, they have said normal, but they have probably not commented about the splenic vein, collaterals. If it is combined with the Doppler, you can look at the artery and vein specifically. Can we go back to the ultrasound report? I don't know whether IHBR was mentioned specifically.
Not mentioned.
Normal.
Not mentioned.
So
Normal.
They
okay.
said
Yeah, show us the other investigations which were done. Let's proceed. Show us the blood in
Yeah,
the
CBC, complete hemoglobin.
Is the screen visible?
Yes.
Yes, sir.
Yeah, keep
It's normal,
describing.
sir. So hemoglobin is, I don't know what was the previous hemoglobin. So 12, I take it as the normal limit, and platelet is normal, count also normal.
Is
Next.
12 normal for a young man?
Hemoglobin of 12 in a male is not normal, it is low.
Yes, sir.
Yes.
RFT within normal limit, sir.
Okay, next.
Liver function test.
Yes.
What
And
are
there
you
is a AT reversal is there. Other than that, everything normal.
What were you looking for in the LFT?
The ALP.
You say that there is no evidence of biliary obstruction. We can all see the numbers. You have to give the interpretation. You should have said that there is no evidence of biliary obstruction and his serum albumin is low.
No.
3.4 in a young male is a low serum albumin. Normally, for any surgical procedure, as surgeons, we target for 3, but 3 is not normal. 3.5 is not normal. It is low, but it is acceptable. Okay, next.
What do you want to do further?
CRP.
What?
CRP I want to see.
Here?
CRP.
CRP,
Wants
sir.
to look at the CRP. Why do you want CRP?
Any acute inflammation is there, and I want to know. Any acute
What is the
inflammatory
role of
changes.
CRP in chronic pancreatitis?
Recent no, sir. Acute and chronic pancreatitis, there is a acute exacerbation, recent history of any acute exacerbation. So just trying to see the CRP.
So from the history and from the ultrasound report, is there any suspicion that he is having acute on chronic pancreatitis at this time? I think he got disconnected. Are you there, Dinesh? I think he got disconnected. Yeah. So from the history and from the ultrasound report, is there any suspicion that at the moment the patient is having acute on chronic pancreatitis?
Are you audible?
Yes, sir, you are audible.
You can off your video and then just keep your microphone.
Dinesh, you are muted. Unmute yourself and you are logged in from
Yes,
two.
sir. Am I audible, sir?
Yeah, don't
Sorry,
log in
yeah.
2 devices. I can see your name at 2 devices. Log out the other one. Yes. So the question was, from the history and from the ultrasound report, is there any doubt that he is having acute on chronic pancreatitis at this moment that you wanted a CRP?
Nothing, but intensity in the last weekly for the last 6 months or 1 year, sir. So I don't know when was the last acute exacerbation.
No, Dhanesh, the
And
question here is,
pulse rate also is 90. There is a severe pain. There may be any inflammation is there or not. I want to know.
Yeah, CRP was not done.
And C 19-9 I want to see.
I mean, one approach could be that you could say that in every patient with chronic pancreatitis, especially if you are planning to operate upon the patient, you would like to know whether the patient is having acute pancreatitis. So you would get a amylase lipase and CRP done. But Since these are expensive investigations, I would suggest that unless there is a suspicion in the history or on ultrasound, you said that history, there is no suspicion. This is a recent ultrasound,
don't know.
Yes.
which doesn't show any peripancreatic stranding, edema, fluid. So the suspicion that he's having acute pancreatitis is very, very low.
Mild pain only. Last attack of pain was just 1 month back.
CA 19-9 normal, sir.
Yeah. Yes.
So what do you want to do next?
Yes.
So I want to do a CCT abdomen pancreatic protocol, sir.
Why?
Yes.
What do you?
What do you mean by pancreatic protocol?
So it is a multi-detector scan with more than 64 slices. The slice thickness will be around 1 to 3 mm. Positive contrast around 300 to 500 ml given rapid phase by using the pump. You have to see in a 3-phase late arterial phase, pancreatic parenchymal phase, and the portal venous phase, sir. To able to describe the pancreatic artery.
Say the phases again. Mention the phases again.
So early arterial phase, late arterial phase, and portovenous phase.
Okay, let's see. So all students should know at least the basic principle of all related investigations, whether
Limit
radiology,
control.
whether endoscopy, whether
Can I have
nuclear.
I'm not able to.
You don't have the control.
I have given you control. You
Yes,
can
sir.
have.
You have the control. Try to manipulate. Try to move the image.
Not able to move, sir.
Yeah.
So there is a question by J. Loganathan.
Ah,
Do we have to do CA19-9 in all cases of chronic pancreatitis without mass lesion or malignancy suspicion? I am not sure whether I can give a definite answer, but I would request the other panelists also. I would say that, yes, I would do it only when there is a suspicion. In a plain, simple chronic pancreatitis where there is no suspicion, I would not do it, but maybe some units may be doing it as a routine. Nagaraj?
Yeah.
Venuma?
Yeah. In patients who have significant history, like say loss of weight or change in symptoms, one has to do CA19-9. But if suppose, this is a common problem wherein patients come, from distant places, once a year visits, it's worth doing a CA19-9 in those patients.
So you do it as a routine in all
Routinely,
patients with
yes.
chronic
Yeah, routinely.
pancreatitis?
Yeah, routinely, especially if the follow-up is, slightly delayed, like 1.5 years
As a baseline.
baseline. That's it.
Dr. Venu Madhav, what is your practice?
They're definitely indicated when suspicion of malignancy is there, like recent change in character of pain or recent worsening of diabetes or suspicion on imaging, but otherwise very selectively use.
So as I said that the practice may vary from place to place, but Dr. Nagaraj has a point that since these patients have a risk of developing malignancy in future, if you have a baseline, it becomes good for comparing it. Suppose after a few years there is a rise, then you can have a suspicion. So there is no harm in doing it. We were not doing it as a routine in all patients with chronic pancreatitis. We were doing it selectively when there was a suspicion. Pradeep, what would be your practice?
We definitely do as a first option of these patients. When first contact, we definitely do in all patients.
Okay.
And definitely in case when there is a suspicion,
that's so.
but it forms a baseline.
So again, as I said, that there will not be a single correct answer to most of the questions, but whatever answer you give, you have to justify. So if you take what Dr. Pradeep Prebala said or what Dr. Nagaraj said, you can justify saying that it forms a base, although I have no suspicion of malignancy at this point, but these patients can develop malignancy later, so it forms a good baseline for me. So you can justify it saying that. Yes, please show us. Show us the important findings.
So it's a plain city and abdomen. Liver contour appears normal, and multiple stone load in the head region of the pancreas.
Only in
No
the head?
pleural effusion.
Only in the head?
No,
Go
sir,
up?
I just don't. Head and
It is all over.
neck of the region and the body, tail, almost all
Yeah, it is all over the pancreas.
over the.
Yes, carry on.
Show the head and uncinate also.
So a correct description would be extensive, large calculi in all parts of pancreas, including head, uncinate process, body, and tail. Your description of an image should be such that even if I am not looking at the image, a picture is drawn in front of my eyes.
Oh. Okay, continue.
Arterial phase.
Arterial phase, okay, take that. Arterial phase, what are you looking in arterial phase?
If it is any mass, we can see, sir, whether it is a enhancing or not, and then any arterial complication of the suppose in case of a pseudoaneurysm, I can look for a pseudoaneurysm. Then arterial anatomy. So suppose in case of if I plan for surgery, I want to look for arterial anatomy.
Okay. Go ahead.
There is a question by NS Harish that whether there is an early arterial phase. Yes, early arterial phase is especially when you are suspecting a neuroendocrine neoplasm. So Nagaraj and Venu, he mentioned that arterial phase is to see the mass in the head of the pancreas.
Yeah,
Is he right?
I mean, only the
Portal phase,
arterially,
you can see, sir.
only the arterially enhancing masses, which usually, in conditions like neuroendocrine tumors. But lesions which arise in the setting of chronic pancreatitis rarely, have good enhancement on arterial phase.
Yeah, I thought that they would be seen as a
hypodense lesion.
hypodense or hypointense
Portal vein.
mass in the total venous phase. That is what I thought.
So early arterial phase mainly to rule out aneurysms. However, you have to interpret carefully in both arterial, portal, and venous phase. Any hypodense lesion is there and how it's enhancement. So you could
which artery are you expecting or anticipating to see a pseudoaneurysm?
The most common is a splenic artery, followed by gastroduodenal artery.
Show us both these vessels. Trace the splenic artery.
Yes, sir. Sir, I am not able to control it properly. Moving fast.
Okay, then show us the findings.
So this is the
Okay.
this is the splenic.
Yeah.
Yeah, so that is the
Splenic
celiac axis.
artery.
You could see bifurcation and you can see the entire course of splenic artery. And all students should remember the splenic artery runs on the posterior surface of the pancreas. On the superior border of the pancreas, whereas the splenic vein runs on the posterior surface of the pancreas.
Please comment first. So, are you seeing anything in the pancreas is suspicious or no?
No, sir, I am not able to see. Pancreas is enhancing, uniformly enhancing.
Where show the enhancement?
Just,
Where is the pancreas?
this. In the head region, there is a hypertrophy.
No, you said pancreas is enhancing uniformly. Where is the enhancement? You're just in the arterial phase, so except for kidneys, the liver is also not enhancing.
You should comment on the parenchyma in the portal venous phase. Here you
With
should
the maximum.
be on the arterial anatomy and arterial any complication like sugar. Okay, go to the portal
Then
space. Show the pancreatic parenchyma.
What are you looking for at this stage?
Any any mass is there or not
Head
in the
mass, okay.
pancreas, and relation to the mass to the vessels, portal vein, portospleen,
Any hypodense
mesenteric
lesion?
spleen. In the liver, there is any lesion is there?
No. First comment about pancreas. You are looking for any mass lesion or hypodense lesion in the pancreas. One is you said bulky pancreas. Then
Do you see pancreatic parenchyma?
This one.
you should be looking for any peripancreatic stranding, collections. So please show us all those things.
See, wherever you are seeing
No collection, sir.
around
No
that,
collection, portal spleen vein. So I'm not able to appreciate any mass.
When you say mass,
Per se.
when you say pancreas head mass, chronic pancreas head mass, when do you say?
So if it is a hypodense compared to the rest of the pancreas, there is any hypodense lesion.
Lesion, okay. Hypodense lesion is one thing. Then
And then hypoenhancing.
the rest of the pancreas, any hypotense, hypoenhancing, that is the same thing, hypotense or hypoenhancing mass. Head. Then
Yes,
when you say it's bulky head, it's more than 3 centimeters, say, but what are you looking? You're not telling anything about the pancreas. Please comment on the pancreas. After the plane, you have seen both arterial and portal vein case. What is your interpretation of this imaging?
So there is a multiple stone extensively in the body and tail.
Yeah.
With dilated duct in the.
Yeah. Did you see the duct? Yes.
Dinesh, while you read a image, you have to first, comment on things which are there. Try to look for things which are there, and then try to look for, things, you mention about things which are not there. So you have to mention about the pancreas, the duct, the parenchyma, if there are stones and strictures, the pattern of distribution, and then the fluid surrounding it. Right? You haven't commented anything. You straight away went to masses.
I'm not able to control, so that's why I'm not able to move forward.
No, but from what you have visualized, you should be able to describe the, morphology of the pancreas here.
In these cuts, in the lower part of the head of the pancreas, in the caudal part, in front of the right renal vein, is there a hypodense mass?
Hypodense.
Yeah.
Uncinate.
Yes.
Hypodense in the uncinate region.
I thought that there is probably a mass in the caudal part of the head and uncinate process of the pancreas. Inside that mass, I don't see any calcification. That is one way that you can differentiate an inflammatory mass from a malignant mass. Inside the inflammatory mass, you may see calcification, but inside a malignant mass, you would not see calcification. So the rest of the head of the pancreas is densely, heavily calcified. But this part, the caudal part where there's hypodense mass, I thought it is there. Inside that, I don't see any calcification.
Do you think the duct is dilated?
Mass is very closely within the right renal veins.
Nagaraj, Venu, Madhav, do you agree?
I think what you are interpreting has, possibly you're interpreting the IVC has, mass. But here, yes, this cut, can you freeze that? Yeah. So inside, yeah, that's right. I mean, inside the lumen, there appears to be some, more slightly enhancing lesion
Where is the
inside the
duodenum? Can you see the duodenum?
Yes, sir.
Where? First we have to identify the structures, no? IVC, duodenum.
This one.
So identify, do you have any hypotenuse lesion? Yes. That is the duodenum, yes.
And the
Yes, there
papilla,
is a hypotenuse lesion.
very, very prominent papilla, large papilla projecting
Yeah.
into duodenal lumen. Okay, let's see the radiologist's impression. We are already at 9.
Is there any acute pancreatitis changes? Do you think?
No, sir.
Are you able to define all the borders of pancreas well defined?
No, sir.
Then
No. Seeing
yes,
fat
read the CT
stanting.
scan image.
I'm not able to.
So here we have the CT report. How do you interpret it now?
So there is a diffuse pancreatic parenchymal atrophy with a dilated pancreatic duct with loaded with multiple stones, largest in the head region, with even the side branch ectasia with the intraductal calculi also present, and there was one more polypoidal lesion in the periampullary region, sir.
So they haven't any mass in the head or uncinate process.
No.
No. How do you interpret this? They have given two things. One is there's a enhancing mass for soft tissue lesion in the medial duodenal wall in the periampular region. And of course, atrophic pancreas, dilated duct studded with stones, enhanced side branches also are enhanced with intraductal calculi. So how do you interpret with these two reports?
Background chronic calcific pancreatitis with one more source of polypoidal lesion, sir, in the periampullary region.
Definitely there is chronic pancreatitis, yeah. Then
along with the lesion in the periampullary lesion.
what are you suspecting? What is the normal finding? Where do you suspect even if mass lesion is there, where do you suspect in chronic background of chronic pancreatitis? Interpret, no, they have given two findings.
Yes, sir.
Is it chronic pancreatitis with malignancy head mass, or is it both lesions are separate, or do you think both are what is your suspicion based on
Different thing.
Is the
There is a head
CT
mass
is the
along
CT
with the
picture
CCP with the head
suggestive?
mass.
Is the CT picture suggestive of a malignant change of chronic pancreatitis?
No, sir.
It is not.
No mass.
You in that you will see a mass in the head of the pancreas. Not a mass in the head of the pancreas. This is a soft, well circumscribed, enhancing soft tissue lesion at the
Periampullary polyp.
So which is not what you would expect in chronic pancreatitis with malignant change.
Yes, sir.
So
Two different entity.
And there is no way that you can put 2 and 2 together. So you should say that I would like to evaluate it further. How would you like to evaluate it further?
So I want to do a side viewing endoscopy with biopsy, sir.
Yes. Yeah, again, NS Harish says that suspicious head mass, bulky head. That is what I also thought, but probably we were not correct. Radiologists felt that there is no mass in the head of the pancreas.
No obvious mass.
Yes.
No. What is the first line?
Floppy papilla.
What does it indicate? Is it normal? What is floppy papilla?
Floppy papilla.
What do you think?
Due to some polypod deletion, it's projecting.
I don't
In
know
case
what
of
to interpret with floppy papilla. Is it wide open papilla or some bulging papilla? What is this floppy papilla? How do you
sorry, sir.
interpret?
So
There are two things. One is bulging
whether
papilla or a wide open papilla. How do you interpret between these two things?
fish mouth appearances, there are not. It's a widened papilla.
Okay. White papilla can be seen in
In
when you see
IPMN, sir.
in IPMN or after the splenectomy sometimes.
Yes, sir.
So they have definitely mentioned that there is no obvious mass,
Yes, sir.
but there is a wide open papilla. So how do you interpret?
So whether they're not mentioned about any mucin secreting mucin they have seen in the papilla also. Right?
So how do you want to proceed further from this? There are
From
two.
the
What investigation can further evaluate this dilemma, whether it is just a large floppy papilla which is appearing like a polyp in the lumen of the duodenum, or is there something inside it?
the endoscopic ultrasound to look for any
Why do you take so much time to come forward with what next is to be done?
by
Has it been done?
US was not done, sir.
Have we got any other investigation done for this patient?
No other investigation, sir. It was a benign.
Suppose endoscopic ultrasound shows that there is no mass, it's just a bulky papilla. On side viewing endoscopy, you should have said that although it is not mentioned, which means that it is not there, but you should, as a student, say, I would have liked to know whether there is any nodularity, ulceration, irregularity, from where a biopsy could have been taken. Obviously, they thought that everything is normal. That is why they haven't mentioned any biopsy. Otherwise, they would have taken a biopsy. But in the exam, you should mention that I would like to know that. Okay. So let us presume that endoscopic ultrasound is normal. And do you want any other investigation?
What sir is telling, endoscopic ultrasound has told that is that whatever that enhancing mass they couldn't identify and just
So except for chronic pancreatitis changes, dilatation of the duct, calculi, there's no mass. This papilla, which is large and floppy, is normal. Do you want any other investigation, or you want to proceed with the treatment of this patient?
OGD scoping.
Okay, was it done upper GI? Let us presume it is normal, no varices.
Upper GI was normal, sir.
Just wait, Dr. Shastri has made some comment. Dr. Shastri says the wide open papilla is sometimes seen with a large calculus stuck in the ampulla. US is the obvious next step. So that is one possible explanation, that there is a stone which is in the ampulla. Now all students should understand the difference between ampulla and papilla. Unfortunately, many students confuse between them. Ampulla is the dilated common channel formed by the distal CBD and the terminal part of the pancreatic duct. The place where the ampulla opens on the medial wall of the duodenum, second part, is the papilla, the nipple-like projection. So what is seen on side viewing endoscopy is not ampulla, it is the papilla. So what Dr. Shastri is saying, that if you have a stone stuck inside the ampulla, it will produce a picture on side viewing endoscopy or on CT, as we saw, that there is a prominent papilla, a bulky papilla, a floppy papilla. But that would very well be seen on endoscopic ultrasound. And Dr. Pradeep says that he discussed with endoscopists and they felt that this papilla is normal, and that is why no suspicion of malignancy, and that is why probably they did not take a biopsy. So we are at that. Now, do you want any other investigation, or you want to plan the management of this patient? We have just 10 minutes more, then we will open to other panelists.
Sir, patient's albumin is 3.4.
I didn't ask that. What was the question? Do you want any other investigation?
So I want to do no other investigation.
Okay. Do you want an MRCP?
MRCP. In CT, I'm not able to see any mass. So US also, it's more
Do you want
sensitive.
an MRCP?
No, sir.
This is again a very frequent mistake which all students do in the exam. When a question is asked, first answer the question, then give the justification. Do you want an MRCP?
No, sir.
Why not?
So it's a dilated duct. US also, so in this case, they didn't, sir, side wing endoscopy.
Say
US
that
not
whatever
done.
your answer should be, whatever information MRCP can provide, I have already got on the CT scan, side viewing endoscopy and endoscopic ultrasound, which based on which I can decide the plan of management of this patient, and that is why I don't want it.
Okay, when you will do MRI in case of chronic pancreatitis? When you want to do MRI? Not necessarily MRI.
Suppose in case of any cystic lesions, suspecting any cystic lesion, and then either it is communicating with the duct or not,
we are
I want
talking
to see
about.
MRCP. Sir?
In this chronic pancreatitis we are talking about. So when you do an MRI, never required CT is enough, or will require MRI also?
So if it is a duct, any cyst communicating with the duct, like complication of the chronic pancreatitis, pseudocyst is either communicating with the duct or not.
If pseudocyst is there, MRCP. Okay, then.
You could say that some groups would probably, after an ultrasound, straight away go for an MR imaging and MRCP rather than a CT scan, because the ductal evaluation is better. And you are right that cystic lesion evaluation is better with MR. But once you have done the CT and endoscopic ultrasound, which has given you all the finding, then probably you are right that MRCP in this particular case may not give you any extra or additional information.
So sometimes in inflammatory head mass, diffusion weighted imaging and all newer techniques may give more information than CT. So that you should be aware.
What is diffusion weighted imaging?
The diffusion weighted image, there is a restriction in the malignant mass, sir. So apparent diffusion coefficient will be low in CA than the benign disease, benign head mass.
So this question again is a very favorite theory as well as Viva question. How do you differentiate between an inflammatory mass and a malignant mass? So you start from the history. We already discussed what are the pointers in history. Then you come to investigations, including tumor markers. Then you come to imaging, the CT and MR findings, depending on whether inside the mass you are seeing dilated duct or not, inside the mass you are seeing calcification or not, diffusion weighted imaging, and then of course PET scan, endoscopic ultrasound, and endoscopic ultrasound guided FNAC. And in the end, you have to say that still, in spite of all these investigations, in some cases, it may still not be clear, because even an endoscopic ultrasound guided FNAC, if it is negative, it doesn't rule out malignancy. So there may be some cases where just based on suspicion or you can't rule out malignancy, if the lesion is resectable, you may have to go ahead with resection. And resection is one of the options of treatment of chronic pancreatitis, even otherwise. So that is how you have to answer. Okay, so what would you advise this young man for his treatment?
I will advise the surgical management in like trace procedure, sir.
Straight away, he hasn't received any medical management.
The patient has received almost for last 1 year, even for last 6 months IV analgesic. So patient actually first last 1 year, patient has interference in daily activities, quality of life also are severely affected. He is not going for the job. So in this condition, I will counsel the patient, and the patient, you may need surgery. It will improve the quality of life. But I will also counsel the patient, it is not a permanent solution. There is a chance of recurrence of the disease. Pain will you will still get. But 80 to 90%, there is a relief of pain.
Would you like to try medical management first for some time in this case?
No, sir.
Why not?
Already patient had tried for last 6 months.
Suppose
Already
he,
they have tried 6
suppose
months.
he had not taken part. Suppose he had not taken part. He comes to you for the first time.
If the patient comes to me, then I will go for the medical management for the time, and then followed by.
What medical management?
In this case, I won't go for. I will go for, if a medical management fails, then I will go for a surgical management, sir.
No, medical management. Suppose patient came to you now. So what sir is telling is not taken any treatment, has been having pain for last days, increase in severity. He came just to you with this imaging findings. How will you treat next? Will you still go for surgery or would you try for
Manage with medically, then I'll go for surgical management, sir.
medical?
No, the question here is if the patient has come to you without any history of being treated medically with this,
Okay, sir.
imaging findings. So what would be your treatment options? And how would you treat the patient? Will you try medical, management for a short duration at least?
Yes, sir. But I will tell the patient if there is a full full calcification present in all over the pancreatic duct, and there is a multiple stone load in the head regions. Even after trying medical management, you may need a surgery. So I will tell the patient to give the medical management at the time, some time being, followed by surgery. Ideally, this patient at last ended with the surgery only, sir, because of the multiple stone with severe pain and worsening of the character of the pain. So,
See, I agree that the standard textbook treatment of chronic pancreatitis is a step-up approach, starting with medical management, endoscopic, and then surgical. I'm not able to give the exact reference, but I think there are recent publications which show that if the duct is drainable and it is a surgically suitable case, then upfront surgery probably gives better results as compared to that you try other measures first. Am I correct?
Yeah.
Raj and
yes, sir.
Madhav?
Escape
yeah.
on trial is there. So escape trial, they compared the yearly surgery versus endoscopically. In that study, they are told yearly surgery improves better, sir, compared to endoscopy, because
My answer would be that if the duct is dilated, it is drainable, there is extensive, both in terms of size and distribution of calculi, then I probably would go for upfront surgical treatment rather than giving a trial of medical management. And obviously, time is short, but this case is not suitable for endoscopic management because you can see the calcification going right up to the tip of the tail of the pancreas, which becomes a contraindication for endoscopic management. So, Nagaraj and Venu Madhav, if you want to make any comments, otherwise we can request the other analysts to make some comments. And before that, students, please send me a mail, vkkapoor.india@gmail.com. Write CP in the subject of the mail. So I will be happy to share the chapters on chronic pancreatitis, both clinical and operative with all of you. So, Venu Madhav, Nagaraj?
Yes, sir. When there's some inflammation, peripheral extensive peripheral standing and some collections, that is case where you're going to definitely postpone till a suitable time. But otherwise, there's a case for surgical upfront. But of course, initially medically followed by surgically is also a good option in some cases. Even though, yeah.
Dr. Nagaraj?
Yeah, nothing. I think we'll go to the other faculties.
Pradeep, we can request.
Dinesh, overall it's okay, but I think when your treatment part, as Professor Kapoor was telling that we should stress more on treatment, I think your answer was not to that level of a super specialty. When Professor Kapoor has asked you, this patient, do you want to go for conservative treatment? The standard of care as of today, you should have said was, yes, first attempt is a conservative treatment because here there is nothing else except for the pain, right? If a patient has not taken adequate conservative treatment, yes, you should have said that I will give a trial of conservative treatment. Right? If a patient has already taken a conservative treatment and it is failed, then I will opt for surgery. But recent studies have shown that early surgery is going to better results than that. So I will opt in this patient for a surgery because he is a young, fit patient, dilated duct where the surgical results are going to be good. So you have to justify that way. So your thought process should be very clear.
Dr. Venu Madhav and Dr. Nagaraj, there are few questions in the chat. Maybe you can take them one by one. Loganathan wants to know when to consider IgG4 in chronic pancreatitis. When would you suspect?
Say IgG4 is when there is, I mean, the first, IgG4 is not a very accurate test, for a diagnosis of autoimmune pancreatitis. First, you should have an imaging which is suggestive of autoimmune pancreatitis. Then only I would be able to, even if the IgG levels are high, the interpretation is in the setting of, typical features of autoimmune pancreatitis on CT scan. So that would be the indication.
Yeah, even in type 1 and type 2 always IgG4 is normal. Even in type 1, only 70% have raised IgG4. So that is exactly what you have to take the whole picture into consideration, not just on IgG4. Then suspicious head mass versus bulky head more than 4 centimeters, yes, 3 to 4 centimeters, more than 3 centimeters, and more than 4 centimeters, definitely yes. More than 3 centimeters also bulky head. Early surgery also after trying medical treatment, already Pradeep sir has given the explanation. So, especially justified in trying medical management, of course, it's upfront surgery. You don't try to postpone too much in this case, surgery, even if you are trying medical management. Once there is no inflammation, definitely surgery should be considered early in this case. Then role of routine frozen and frozen in suspicious cases during place. Yes, especially when this head mass is there and bulky head, better to send frozen sections. And especially after all investigations also, sometimes malignancy is missed. Sometimes even there are cases when frozen section also misses the malignancy because it's all inflammatory process. We have instances when the frozen section was negative and final biopsy also came as malignancy, especially in chronic pancreatitis, long duration and symptoms with recent worsening of diabetes and weight loss. Always malignancy should be considered. And frozen section should be considered in all suspicious cases.
The only thing is that if you want to do an intraoperative biopsy, it should be a transduodenal, preferably intraoperative ultrasound guided core biopsy from the center, not from the periphery. Periphery is going to be false negative. It should be from the center of the mass, which is more likely to be positive. But again, a negative frozen or intraop biopsy doesn't rule out malignancy. So in most of the cases, you go by your degree of suspicion. If you have a suspicion, it is better to go ahead with resection, because once you have done appraise, you have violated the oncological plane. And for chronic pancreatitis, pancreatic duodenectomy is an acceptable form of treatment. So there's nothing wrong in doing that.
If there is a preoperative suspicion of cancer, it's better to proceed with Whipple's rather than do biopsy and rely on, the intraoperative biopsies.
How much time we can wait before we plan for surgical procedure to prevent central sensitization of pain? So all depends on the clinical scenario. Like in this case, where surgery is definitely indicated, we do not postpone surgery too much, but we have to consider every patient as individual case and then decide for surgery in each case. Can we go to the last question, sir?
Yeah.
Without pain or only mild pain, but having dilated duct with stone throughout the entire duct and dilated, does this scenario require surgery? No, the indication for surgery is very well defined. It's only pain. If there's no patient doesn't have pain, you can wait. But of course, you have to rule out malignancy and other things. But only dilated duct without pain and patient is well stable, then probably surgery role is not there.
Dr. Shastri?
Shastri?
I think it's straightforward case as far as the diagnosis is concerned. There's absolutely no problem. We can have any amount of discussion. But I agree with Pradeep in your last comment about the treatment of this condition. So now you should understand the clinical problem in this patient. He's a young man who is used to 90 to 120 ml of whiskey every day. And then he has a suspicious steatorrhea. He has, of course, unrelenting pain and a heavy stone load. That would indicate definitely a surgery. But in this setting, you must remember that surgery in any chronic pancreatitis is only a palliative thing. It will relieve your pain. But I would hesitate to operate on him immediately. I would rather counsel him, wait for a month, see that he stops his alcohol and smoking. Only then. Meanwhile, I would assess his exocrine dysfunction by putting him on enzyme replacement as a treatment diagnosis. Say once you put him on treatment, you would know whether he really has steatorrhea or not. All the other tests, fecal fat and this fecal elastase are fine. But ultimately, the functional aspect is how much enzyme replacement he would require now and later after surgery. So surgery may not have the desired effects if he starts drinking again. I think this is one aspect you you should have emphasized in the overall management.
About the last question, I would like other colleagues also to comment. I have to admit that in few cases, very small number of cases, which were largely asymptomatic, not meriting surgery on the conventional grounds, when it was a hugely dilated, easily drainable duct with large calculus load almost in the entire pancreas, like in this case, I have to admit that after explaining everything, I have offered surgery to some patients.
And there have been some papers, which suggest that if you operate early, the progression of disease can be, slowed down. But, those are, few isolated papers. We cannot reach to a definite conclusion based on those.
In fact, in one of his lectures, Dr. Sikora presented a Japanese paper, I am not remembering the reference, where it was shown, although it was all retrospective, that drainage decreases the risk of malignancy also in chronic pancreatitis. So there is very soft, very little evidence that the endocrine exocrine dysfunction may be halted and there may be some decrease in the risk of malignancy. So very soft ground. So that is why I said in very few selected cases where I knew that surgical procedure is going to be easy and there is very less likelihood of a post-operative complication. After explaining everything to the patient, I have offered surgery to some of these patients.
Early surgery is fine, but this particular patient doesn't qualify for as an early case. He has this unrelenting pain. He has enough indication for a direct surgery. So I don't think he would qualify for to be labeled as early surgery.
So your approach would be to give him 3 months of pancreatic enzyme replacement and then surgery?
Stop alcohol first. I see that he stops alcohol for at least a month.
Because pancreatic enzyme, even after surgery, most probably he is going to need. Because whatever atrophy has already occurred, that probably would not get reversed. So his steatorrhea probably would persist. Only the pain probably would get relieved. Pradeep, what would be your timing of surgery?
At least we'll give adequate conservative treatment before we take a call, sir. And we intervene before the
conservative treatment, expecting a response, or
yes. And this patient definitely, as Dr. Shastri has pointed out, that he requires a counseling of stopping alcohol, which usually requires about 3 to 6 months for the counseling, whether it is effective or not, because there is no urgency to go in. And also before the patient goes on to any of these higher analgesics like sedatives and those type of medication, simple painkillers is not a problem when they go on to tramadol and other drugs. Before they go into that, we try to intervene if it is feasible for intervention, like a dilated duct and all those things. I would definitely also do an endoscopic ultrasound and rule out a stone stuck in the ampulla and try to relieve him of his immediate pain.
Yes. Although from the history, it appears that this is interfering with his work. Most probably he has received opioid or opiate injections, and it is very unlikely that he is going to respond to conservative treatment, so much so that you can avoid surgery. And I don't know whether the condition that he should stop taking alcohol applies in a case like this, as opposed to, say, a alcoholic liver transplant. I mean, even if he continues to take alcohol, if you do a surgical drainage, his pain would most likely be relieved and he can go back to his work. So is it an absolute requirement in an alcoholic chronic? Is it alcoholic chronic pancreatitis? Because this picture is of tropical specific pancreatitis rather than chronic pancreatitis.
Yeah.
I can't ignore his 120 ml of whiskey every day.
Then definitely the surgical results will be better. I'd not say that if we counsel him to stop the alcohol.
Yeah, I would take it as a part of treatment rather
Yeah,
than
correct.
a requirement.
Exactly.
So that is another point which Dinesh should have mentioned, taking his alcoholic history, that psychological evaluation and consultation. So in patients with chronic alcoholics, in patients who have had intentional corrosive intake, students forget this aspect of management. This aspect has to be mentioned from your side somewhere when you are describing the plan of management.
So there are a few more questions. Like if you're doing a Whipple's procedure, do you have to lay open the duct? Yes, in this case, you have to lay open the duct, in case a Whipple is,
Yes.
planned.
Yeah.
Yes,
And
sir.
upper level of CA99 in chronic pancreatitis without mass. And see, there are no definite answers for this. If you keep a higher cutoff, like something like say 500, then the specificity increases. But then you pick up masses, much later. There is, in fact, if you want to improve the accuracy, it should be more than 1,000. But then you end up picking up, masses very late. So are we talking about early surgery or upfront surgery? Kindly clarify. See, early surgery, it's not like, there's no definition of early surgery here. Here we were discussing about patients who come and you're not, like start the patient on medical treatment. This patient doesn't qualify for early surgery here because, patient is having symptoms for 4 years. But then if some patients come to you without symptoms, but imaging suggestive of chronic pancreatitis, that would be, and then there would be patient with very short duration of symptoms, but the anatomy is very, very favorable for a surgical treatment. So those are conditions where, where you consider as early surgery because there would be an option of treating conservatively. Shall we wind up the show, sir?
Any
Yes.
doubts, Pradeep?
Yes, sir. Thank you, Professor Kapoor. Thank you, Nagaraj Palankar.
Thank you, Dr.
And
Nagaraj. Thank you.
Thank you, sir. Thank you, sir.
thank you, Professor Shastri. Thank you, Dinesh. Thank you.
Thank you.